and welcome to General Session 2. My name is Angie DiMichele, and I am from the University of Pennsylvania. I'm going to be moderating today, and I am joined by my colleague, Bill Gradishar from Northwestern University. Welcome to those of you at home. We miss you here. Welcome to those of you who are here in the building. Just a reminder that when you're here in the building, you cannot submit a question. So we have a couple of mics here if you want to ask a live question. But for most of you at home, you're going to submit your questions online on the platform, and we'll see them here, and we'll ask them for you. So without further ado, let's go ahead to start our first presentation. Our first presenter is Lisa Carey from Lineberger Comprehensive Cancer Center, and she will be presenting correlative analysis of overall survival by intrinsic subtype across the MONALEESA-2, 3, and 7 studies of ribociclib and endocrine therapy in patients with hormone receptor positive, HER2 negative, advanced breast cancer. Lisa.
Thank you, Angie, and thanks to the organizers for choosing this talk. This being a very hybrid situation, so I actually recorded my talk, not being sure where we would be on December 8th. So if you could play the recording, and then I will come and take questions and answers in person afterward. Hi, I'm Lisa Carey from the University of North Carolina in Chapel Hill, North Carolina. And on behalf of the co-investigators and my co-authors, I'm here to present the correlative analysis of overall survival by intrinsic subtype across the MONALEESA-2, 3, and 7 studies of ribociclib added to endocrine therapy in patients with hormone receptor positive, HER2 negative advanced breast cancer. These are my disclosures. Ribociclib added to endocrine therapy demonstrated statistically significant improvements in progression-free and overall survival in 3 phase 3 clinical trials, MONALEESA-2, 3, and 7, in patients with hormone receptor positive, HER2 negative advanced breast cancer. A prior pooled analysis of patients in these 3 trials demonstrated a significant progression-free survival benefit with ribociclib added to endocrine therapy compared to placebo and endocrine therapy in luminal A, luminal B, and HER2-enriched subtypes. I call your attention to an additional meta-analysis of progression-free survival by intrinsic subtype in hormone receptor-positive metastatic disease that's going to be presented by Dr. Shattini in poster session 4 at this San Antonio meeting. This retrospective exploratory analysis is going to evaluate the association of intrinsic subtype with overall survival using tumor samples pooled from these 3 MONALEESA-2, 3, and 7 trials, made possible now by the fact that MONALEESA-2 has had overall survival has now been reported. Tumor samples, primary and metastatic, underwent gene expression profiling using a customized nanostring encounter GX 800 gene panel, including 36 of the 50 PAM50 genes. So the intrinsic subtyping was performed using a 152 gene set that was selected based on its ability to accurately identify PAM50 subtype in independent tumor set and the original PAM50 microarray training data set. The relationships between PAM50-based subtypes with survival were evaluated using univariable and multivariable Cox proportional hazard models with Kaplan-Meier curves and median overall survival estimates by subtype and treatment arm. Multivariable models were adjusted for known clinical covariates. The p-values here are descriptive and were not adjusted for multiplicity or false discovery. What's shown here are the tumor sample subtype distribution in this data set. This is 997 samples from the parent trial. It's a slightly smaller number because of the exclusion of normal-like subtype in this analysis. And you can see that the ribociclib plus endocrine arm and placebo plus endocrine arm are both well represented, and that the MONALEESA-2, 3, and 7 trials each contributed significant numbers of samples, and so all are well represented also. 71% of the subtyping was done on the primary tumor in the pooled data set. The remainder were from a sample of the metastatic disease, and you can see this was generally true across all 3 trials. If you look on the left, you can see the tumor subtype distribution, with 54% being luminal A, 27.9% luminal B, just under 15% HER2 enriched, and a small number, 3%, being basal-like. The biomarker population studied here, these 997 patients, are similar to the intent to treat population. What's been previously shown in the pooled analysis for PFS is that the baseline characteristics were quite similar. And what you can see here is that the behavior is also quite similar, with a similar improvement in outcome and similar median overall survival delta between the patients receiving endocrine therapy alone with placebo and those receiving endocrine therapy plus ribociclib, with a hazard ratio of 0.76 in the parent trial and 0.75 in this biomarker population. Intrinsic subtype was prognostic in this data set. On the left-hand side, you can see the placebo plus endocrine therapy arm of the trial. The luminal A had the longest median overall survival at just under 55 months. That was followed by luminal B that was about 10 months shorter, HER2 enriched substantially shorter at 29 months, and the basal-like had the worst overall survival at 21 months. Conversely, if you look at the ribociclib plus endocrine therapy arm, you can see a substantial increase in the median overall survival in luminal A from just under 55 to 68 months, similar to luminal B, just under 45 months to just under 59 months. HER2 enriched went from 29 months to 40, and the one group that did not seem to appear to derive any benefit from the addition of ribociclib was the basal-like subtype. And this slide, in multivariable models, intrinsic subtype remained prognostic. If you look on the right-hand side, you can see the adjusted hazard ratio in the endocrine therapy own, meaning the placebo arm, compared to luminal A as the referent population. Luminal B had a 47% worse outcome, so a hazard ratio of 1.47, HER2 enriched 2.87, and basal-like 2.35. On the left, you see the ribociclib added to endocrine therapy, slight shifting in those that appeared to benefit from ribociclib. So luminal B now had a hazard ratio of 1.16, referent to luminal A, and HER2 enriched 1.83, whereas basal-like did not derive any change and remains with a 7-fold worse outcome. So this consistent overall survival benefit with ribociclib in the luminal A, luminal B, and HER2 enriched subtypes is illustrated here in Kaplan-Meier curves. And this is, of course, a univariable analysis. And you can see in the luminal A, a hazard ratio of 0.75, luminal B, 0.69, and HER2 enriched 0.60. So in univariable analysis, this benefit continues to be seen in luminal A, luminal B, and HER2 enriched. We did not see an improvement in basal-like, but the sample size is small, and we should acknowledge that as making it harder to interpret. There was an interaction test that was statistically significant. However, when eliminating the basal-like subtypes, this was no longer significant, suggesting the basal-like subtype is driving that interaction. Now, multivariable analyses, you can see the luminal A adjusted hazard ratio for overall survival, 0.77 for ribociclib benefit, luminal B, 0.63, and HER2 enriched 0.53. And this again had an interaction test between subtype and treatment arm that remained statistically significant after adjusting for clinical covariates with a p-value of 0.0065. Again, after removing the basal-like subtype, this interaction test was no longer statistically significant. So in conclusion, in this pooled analysis of MONALEESA-2, 3, and 7 trials, there was a consistent survival benefit observed with ribociclib added to endocrine therapy in luminal A, B, and HER2 enriched subtypes. The patients with basal-like subtype did not derive benefit from ribociclib, but this should be interpreted with caution because it's a small sample size. The prognostic value of PAM50-based intrinsic subtype for survival in patients treated with ribociclib plus endocrine therapy and those treated with endocrine therapy alone was confirmed. The results of this analysis are consistent with the prior PFS analysis that used this pooled data set. The activity of ribociclib added to endocrine therapy in the HER2-enriched subtype, which has poor outcomes compared to the luminal subtypes, is being further investigated in the Harmonia phase 3 trial, which will examine if ribociclib has a particular impact in the HER2-enriched subtype based on these clinical data and preclinical data in model systems. and a genomic profiling analysis by intrinsic subtype across the MONALEESA trials will also be presented at this San Antonio meeting by Dr. Pratt in poster discussion session 2. So the authors thank the patients enrolled in these studies, their families, as well as the study investigators, and we also thank the team that supported these trials. Thank you. Please scan the QR code on this slide for additional materials.
Well, that was fun.
So thank you, Lisa. Nicely done. We do have a few questions for you. So I think one that many of us are wondering is, what's the implication of the HER2-enriched and basal-like tumors in a population that was supposed to be hormone receptor positive and HER2 negative?
Well, the truth is they are hormone receptor positive and HER2 negative. Those are the clinical assays that we use to decide what therapy we're going to use. And what we're discovering, as I think you've heard here and at other meetings, is that there's a lot of molecular heterogeneity within the clinical, the clinically ascertained groups of patients. Now, the extent to which that means we should change our therapies is what I think we're all tacking towards. But this is still ER positive, HER2 negative clinically. And I think it brings a very important question to when do we move past and how do we integrate hormone receptors and HER2 using clinical assays, and when do we take the next step with molecular testing? It wouldn't surprise me, I'll just go out there to say, it wouldn't surprise me to find that we still end up with anti-estrogen therapies being the key component of treating these patients. But if you have a HER2-enriched tumor, we already know that's behaving differently, and we may need to bring different therapeutic modalities to bear.
Thank you. There's a bunch of questions really just about how to identify these non-luminal tumors. Is there any other way to know you might be dealing with one of these short of gene expression profiling?
The short answer is no. I think that what people are working towards are molecular classifiers, but they're not in the clinic yet.
So would you say we should think about doing intrinsic subtyping in the clinic? Had to ask.
I think these data are, as we said in the thing, exploratory and hypothesis generating. But I mean, listen, this is the same story we're telling in ER positive, HER2 negative, and HER2 positive. I think we're not too far away from really incorporating these in prospective trials. Like the Harmonia trial actually will give us an answer for that.
And then in terms of this basal-like group that actually did so much worse and worse on therapy, there was a question about whether we think there's something specific about the exposure to this therapy that made those do worse. For example, the biology of RB.
I think it's just that basal-like tumors aren't endocrine sensitive personally. So that's the one caveat to my earlier statement that I think, for most of these patients, endocrine therapy will remain the mainstay. I have to say, I think this is true in multiple data sets, that there's going to be a group in which what we think is the relevant signaling pathway for therapeutic intervention isn't. And I'm guessing that's what's happening in the basal-like subtype. So I don't think you can expect a CDK4/6 inhibitor to salvage, essentially an endocrine insensitive tumor.
Great. There was one last question. So in the HER2 enriched group, were there I guess the question is, were there tumors that were hormone receptor negative and others that were hormone receptor positive? The patients all had to be hormone receptor positive to get into the trial. So.
Correct.
All right. Do we have anything at the microphone?
We have the hybrid online and we now have microphones in the back.
Great. So I think we've covered all the questions. Thank you so much.
Thank you.